Hi, I'm Sarah Bishop. I'm here with Dr. Jesse Selber, and I'm a plastic and reconstructive surgeon here at Cleveland Clinic. And I'm really excited to be here today with Dr. Selber, who is my mentor in robotic plastic surgery. So I met Dr. Selber when I was a micro fellow at MD Anderson. He was teaching there. And those of you who know or don't know, he is the pioneer of robotic plastic surgery, and he has now gone on to greater and greener pastures. He's now the surgery service line chief. Am I saying that correctly?
Yeah, I've got a few titles. I can iterate them for you if you want. I
Okay.
don't want to make you stumble through them. They sound bad enough coming out of my mouth. So,
Well, okay. So tell it. So help
so
me
I work
out.
for Corwell Health East. It's a large health system in the Michigan area, largest employer in Michigan. It has 22 hospitals associated with it and three main campuses or regions. It's got a West region, Grand Rapids, and East region, which is in Detroit and Southeast Michigan, and then a South region, which is called Lakeland. Um, I am mostly concerned with the East region or have leadership roles in the East region. That's 8 hospitals, about 3,000 beds, 150 hours, do about 100,000 surgeries a year. And I'm the surgery service line chief for that, which encompasses 11 surgical services that have things like breast, trauma, plastics, ENT, urology, bariatrics, thoracic, a couple of more. And everything but cardiac and neurosurgery, everything but cardiac and vascular, which is in the cardiovascular service line.
Okay.
It's funny that I forgot neurosurgery because I'm also the interim chair of neurosurgery, which is a whole other story that I won't tell in this podcast. But hopefully that's
We'll get an appendix.
temporary post. Yeah, yeah, exactly.
Be good.
And so, Vice President of Strategy and Growth, Surgery Service Line Chief, those are slightly different bodies of work with different reporting structures. Interim chair of neurosurgery, kind of a one-off, and then a professor of plastic surgery where I do the work that you're probably more interested in, which is the clinical work that I do.
Well, we are interested in all of
We're
it.
going to cover all that stuff? Okay.
No, but we're interested in all of it.
Okay.
But yeah, cool. We're going to cover almost none of that. We'll see. So Dr. Selber's here with us as a visiting professor. And so last night we had a nice dinner and he gave a talk on kind of economics and surgery and robotics. And then gave kind of an impromptu talk on kind of career development because he has, a fascinating specimen here with being a plastic surgeon, but also very high up in leadership. And we don't have a lot of that in plastic surgery. So yeah, it's very cool that you're representing for us because I think all the specialties were kind of very different from all the other specialties. I think have a lot more in common than we do. And we did a cadaver lab and then now
demonstrated the robotic deep
down on this, like
the origin story. Yeah, so my origin story with that was I was at Penn and I was a mid-level resident. And at that time at Penn, Bert O'Malley and Greg Weinstein, who are two, one was an OMFS, one was an ENT doc, and they were experimenting with transoral robotic surgery at that time.
And let's remind, at this point, you're a plastics integrated resident, correct?
Yeah, it was a combined residency, so 3 years of general, 3 years of plastics.
Okay.
And I was at about year 3 or 4. I can't remember which.
Okay.
Probably 4. Because this was around 2005, 4 or 5.
Okay.
And I was sort of watching as they did this work, and I asked one of them, what are you doing about the defects of the oropharynx that you would need soft tissue for, or if you expose the carotid posteriorly, or if it's radiated. Mm-hmm. And they said, well, we just leave it open to granulate because we don't have anybody who can do reconstruction back there, who can sew, put slabs back there, who can get vascularity out. And I said, have you asked anybody? And they said no. And so that gave me the idea of, geez, maybe there are some applications, because I really like head and neck at the time. I found it.
So they are doing some resections robotically?
Yes.
But they just didn't have anyone that could actually inset the flap.
I don't think they ever really asked or bothered or even imagined it. They just started doing this for kind of T1, T2 tumors. Okay. And they would just leave them open and let them granulate. But people would bleed.
And that are radiated? I mean,
sometimes, yeah. Yeah. Most of the time.
Granulating may be challenging.
Yeah. And also, you don't want to radiate and expose carotid. There's all sorts of reasons for doing reconstruction of the oropharynx that we know
Right.
are valid ones. And so that got me thinking, well, do I need to think about learning this stuff? And I was already in the, I was young and then in the excited, what can we do that's new headspace. I was thinking about VCA a lot at that time.
Yeah.
I was thinking about robotics a lot at that time. And so, short story long, I ended up finding the rep for Intuitive at that time. There was a facility in the Pennsylvania area called Glen Olden that had a robot in it. He had to kind of drive out to it. And I would buy him 6 packs of beer, and he would take me out to the facility. I set up a little dry lab with like a coffee cup and a Penn roast strain strapped to the inside of it, and practice sewing to figure out if I could sew in like.
In which system is this now?
That was the S. So that was the first,
Yeah.
basically, generation of robot. We're on now 5th generation of robots. So that means I'm old. But I was on the S, and
You were just so young.
yeah, right, something like that. And so it was fun. It was different, and I got familiarity with the system. And then by the time I was graduating, I had already kind of done a wet lab, a dry lab, done a cadaver lab, I think, at that point. Hadn't written my first paper on the subject yet, but when I went to fellowship at MD Anderson, I asked my local people, is there anybody over there who's doing tours? And I identified a guy named Chris Holsinger, who's now at Stanford, but was at MD Anderson. And he said he would sort of proctor me and hook me up with a lab there. Found a lab in Houston, met this awesome lab director named Arturo, who...
So are you a fellow now?
I'm a fellow now
you're a
taking
fellow.
time out and like getting internal grants and stuff to fund a cadaver lab.
So you did that during your year fellowship?
I did. Some of us were productive during our year at MD
Wow.
Anderson, Sarah.
I was clinically productive.
You were terrific. I jest. But so I was doing that kind of on weekends and nights and developing. At that time, I was already comfortable with tours, but I was developing the robotic rectus and the robotic latissimus and the robotic mastectomy, believe it or not, and working through all those things in the lab because I knew that when I got to patients, I wanted to be perfectly safe and make all my mistakes on dead people, not live people, as is good to do. Now we would do that probably on a simulator, but that was a really good experience. And I was doing robotic micro back then, also on cadavers.
I remember seeing some of those videos.
So I started then July of my first year as an attending. 3 weeks in, I booked my first tours case and did it. So right out of the gates of starting, I started doing cases during board collection.
And during board collection.
During board collection.
Because I know there were things they didn't want me to do during board collection.
Yeah.
So they were supportive or how did that? Any thought about that?
Yeah. I mean, if I was going to give somebody advice, like go by the book, but I was not willing to be patient. I believed in it. And also,
there's also, you don't want to wait too long to start things.
Wasn't going to wait a year. I'd spend a couple of years.
Well, and to be honest, like you might have to wait longer than that, because if you're trying to actually make sure you don't have to redo the boards.
Yes. I wasn't super worried about that, but yes, that is a concern.
Did those cases get picked?
No. So my supercharged jejunum and none of my tours cases got picked. I think they didn't have people
to ask
really examine it, right? Because you need
someone to be able to talk about it.
Either that or they just missed it. I don't know. It's hard to tell. But anyway, I did it, whether that was good judgment or not. I really felt strongly that this needed to move forward. From the very beginning, I was like, this is the future. This is the future. Yeah. And then I feel like I kind of like screamed about that for 15 years and now it's kind of happening. Like we have these new microsurgical robots. We have, Da Vinci applications that are being used in plastic surgery, particularly the robotic deep, I think is probably the one that landed on the radar of plastic surgeons most firmly and is kind of stuck there, evidenced by it being done all over the country and the world now.
And you started with tours.
Started with tours, went to the LD. The LD was a big detour because that's a hard operation robotically. It's a big working area. It's a tight space. So virtual space, not actual space. It's that you have to make that potential space. And so making that space is actual work. And then the space is still pretty tight, but you're probably used to this doing TEPs, but you're in a tight working area and it's a big area, not just in length, but also around the curvature of the back. And so getting around the curvature of the back and not cantilevering over the rib cage, there's some technical details. So that took me, so I spent a couple of years kind of dealing with that. I actually did a K, which is the device labeling study that you do with the FDA during an IDE, an investigational device exemption. So we did that study
Now,
with
is
the
there a
FDA.
time limit on that? Could at any point they
I don't know if there's
transfer
a statute of
data?
limitations, but Intuitive never took the data and
Right.
actually filed for the FDA.
Just wondering, like at
For
some
the
point,
510K.
are they just gonna,
Yeah, I don't know.
like
It's
in
probably
5 years?
it was like 6 groups of personnel like ago, and so like barely anybody that was engaged in that is still.
And they didn't. There's no funding, right? Like it just.
I mean, I did the legwork. Like I filed
Right.
for the IDE. I would think that they had the work product and it demonstrated,
And you think they don't want to have to support, like what?
it's just not in their core area. I mean, I don't want to speak for Intuitive and their strategic plan, but
Yeah.
there are some, core areas that they want to be in that they feel like maximizes their total number of patients served,
Yeah.
or total potential market.
Yeah. Change.
I do, but well, here's the thing. I think they still have such a big piece of open surgery to bite into,
Yeah.
and what they're really focused on is converting lap and open to robotic in the core areas that they're practicing: urology, thoracic.
But that seems like that's already done.
Yeah, a lot of that is.
I mean, it's so different. I mean, because I did
Right.
the full general surgery, residency, and so I guess that I graduated 2016 from general surgery. I mean, it's completely different. I
Absolutely.
mean, we were just starting to do robotics, and the general surgeons at that time were very anti-robotics.
Yeah.
And basically,
I
it felt
remember
like
that.
it was like, oh, like you're not good enough.
Right.
Only the
Yes.
people that can't operate need a robot.
Right.
And then now they're all doing it. And when I chat with a lot of our hernia colleagues, they get real excited at being able to like maybe walk their hernia fellows through like a laparoscopic
Right, because it's so rare.
Yeah, like they just like never.
I mean, laparoscopy is like the 8-track in the evolution of listening to music. Like it had a period of time when that was the best technology for that, and then CDs came out, and then there weren't CDs, and then there were MP4s, and now they're streaming. So these things they do cycle. Because I remember 2 stages of this. I remember when I was a medical student and people were like, laparoscopy, like just do it open, like it's a waste of time, or it's like you're gonna get a bile duct injury, or like just make an incision this big, you know what I mean?
Oh,
and
there
then
were like, people that were calling malpractice, like surgeons that were like, this is malpractice,
And then within 15 years, it was
standard of care.
Same, yeah, that was standard of care, and same conversation about robotics.
Can you imagine, like, if you had a surgeon that was out there just doing open gallbladders?
Yeah, right.
I mean,
right.
They would lose their minds.
Well, if you had that philosophy on everything, we would be communicating with carrier pigeons and chiseling into stone tablets and sending monographs and stuff like that. Evolution is good, and it goes without saying, I think that when new technology first gets onto people's radar, the initial reaction, especially if they're people who have a stake in the current state of things or the status quo, is, we don't need that. That's a gimmick, or you must be, incompetent if you need. But then again, many of those things, like there's a lot of failures, there's a lot of dead ends on the technology.
And there always is going to be an adjustment period. It's going to take more time in the beginning.
Correct.
All that.
That is also true.
Working through it, and then also working through how to get the technology to meet you. I think that's kind of where I am with, we do the TEP approach for the robotic deeps, and it is more clunky because the instruments are not made for this technique.
Right.
And so, but I do recognize that it will be so nice eventually when we have really small instruments, low profile, that there's no reason in my mind why that won't be great.
Yeah. I think, what happens with technology is faster, better, smaller, cheaper.
Yeah.
Right?
Yeah.
Everything.
So, all right. So then you did latissimus, and then were you doing rectus and before deeps? Yeah.
So in fact, the way I got kind of used to the idea, the way like I got used to the temperature of the water for deeps, was just doing rectus muscle. And like every time I did a rectus muscle, and first you take off the posterior sheath and you take the muscle off the anterior sheath, and you see those big perforators go in, and I would just buzz them and make note of them, be like, oh, this is what I see.
There they are.
Yeah, there they are. And then
I just killed the
dissecting the pedicle is super easy on the VRAM. So was like, well, if it's this easy this way, like, why don't we just, like, is there a way that I can combine these two approaches? I'm looking at the perforators. We can identify them. We have imaging. I'm looking at the pedicle. This dissection's easy.
Yeah.
It doesn't violate any of the strength layers of the abdominal wall. So then I started thinking about kind of the ice fishing metaphor, where like you drill a hole and you stick something in there and then you pull something out of there. And I always think about ice fishing when I'm pulling that long pedicle out, because I'm like,
now I will too.
Yeah, now you right. Now you will too. But I was thinking, okay, well, you know, what's the minimum thing you have to do from above to get to what you want to do from below? And that minimum viable product of dissection is dissect your perforator through the muscle and to the posterior sheath. So then when I started thinking that way, then I pretty quickly came to, okay, well, if this has got a long intramuscular course, probably not a good candidate. And that's probably an open dissection. And very quickly came to, so basically the length of my intramuscular course, if I need to do that open, is going to be the length of my fascial incision. So that is what started to get me to the point where I was like, okay, so now I can tell a patient based on their CT how long their fascial incision is going to be.
Yeah.
Like I'm that sort of refined in the ability to identify the candidate and what will need to be done.
But you're always going to be dissecting longer than your fascial incision, right?
A little bit, yeah.
Yeah. So.
Yeah, you want the fascial incision. You know, that's safe. Like you could shorten it and then, you know, get in the tunnel. Like you saw me today, get under there a little bit. And I'm always doing a little bit of that.
Yeah.
Part of that though is just to lift the anterior fascia off the anterior side of the vessel, the pedicle, because that's the hardest part when you're coming up from below, trying to make sure that you've gotten around everything circumferentially and you break into the plane where you can just pull out and you're not compromising any of the perforators that you've decided to take, is breaking into a circumferentially dissected pedicle. That's what I want to see.
Now, when we have better instruments and we're able to do clipping and easier, faster suturing without having to kind of come in and out, you know, that we just have easier transition to like more instruments. I mean, don't you think almost everyone will be candidates?
Yeah. So, I mean, I think the barrier there is intramuscular dissection. Like, buddy of mine at Anderson said he just tried out a microbipolar, and he thinks that's really nice. So, I mean, I think solvable problem. What is not necessarily a solvable problem that way, though, is you still want to make sure. I don't see any way to make sure your perforators are the ones you want besides actually dissecting and looking at them. So that open dissection, like, I think on some level needs to happen. Yeah. Now, do we need to go through the fascia and go through the muscle from there? I don't know, but, you know, having come from below a lot, once you start to get into an area where there's things that you haven't dissected yet, then you have to start making presuppositions about where is that coming out.
I think so. You had to be mindful. I think, you know, you could probably have better ways of measuring. You know, I do the 3D models for all mine, but I've done both, doing some of the anterior dissection first and not doing it. So with the TEP approach, I noticed that whatever you do first will be easier. Because I've done where we don't do any of that perforator dissection first, and then the robotic part is very clean, and then you just have to kind of transmit, kind of palpate, have some kind of palpating there to like make sure. And it's a little bit nerving. Yeah, because you're like, I definitely want to make sure I'm not bagging what I want. But it is that intramuscular dissection is a little trickier, because when you've clipped, it's just a little bit harder, and it's easier to have a vein injury. Yeah, for sure. But the
muscle jumps around with fused monopolar. And
and you just don't see it as well.
The other thing is, I mean, if you've got to really make sure that you're working the right plan. So you've got to look at, like, if you've got a type 2 and you're starting from below and coming up, like, you need to know which one is going to the perforators you want. And you can plan that without looking at them directly and being like, that's the perforator I want.
So now I'll try to dissect as much as I feel like I can to get to something that looks like it's juicy enough. That I'm like, oh, when I get to this. And then I do like to do the little vessel loop that
I think that's a nice trick.
Like, describes, because there is comforting.
Yeah, that's Dan's technique.
That you get to that. Yeah.
Yeah, so a couple of people have done a couple of things that I think are nice adjuncts. So Dan is the vessel loop guy. I think that's a nice adjunct to this. So what that means is basically you put a vessel loop around your perforator and you can see it when you break into the appropriate plane. I think that's helpful. My buddy Shuck at Anderson puts a little methylene blue on the posterior sheath.
And then they
just
also
as something to go
just
to.
describe. So I think
I don't think you need it.
It's cute.
It's cute. Yeah.
Yeah.
Yeah. It doesn't hurt.
I think, another shout out for Dan Marari that he needs to write about. I know he's presented on it. Is doing, a robotic VRAM with the
small pedicle. The small skin island. Yeah, he's written about it.
Has he written?
Yes.
I couldn't find it.
Oh, really?
Yeah, because I know I've seen him present
about it in his book.
Oh, okay. Well, I've been in an article.
Yeah.
Yeah. Well,
yeah, it's a nice technique.
Dan, you got to get it in an article.
Come on, Dan.
Because keep citing it, but
he's too busy surfing in Hawaii.
Yeah, he's too busy doing them to write about it. So, but I think that's such a technique there. So,
and then there's the whole micro part, which you are very involved with and know a lot about. And I've always thought that was kind of some of the ripest fruit to pluck. It's taken a long time for systems to become capable enough. Even the Da Vinci systems are good enough to do it. So I think that the companies that have done it have done a great job with miniaturizing everything and the movements and the strength testing and the optics and everything else. I would have thought some things would have gone faster than they have, and would like still to see those things accelerate. And what I mean is the entire digital surgery space of predictive analytics, augmented reality, virtual reality, navigation, tissue differentiation, motion tracking, all of that. And then ultimately gated autonomy or autonomous subtasks that can be performed and that you can supervise as a robotic surgeon.
Do you think that will happen? Like, when are they going to do the first?
So I've been bad at predicting this. I'm very good at predicting where it's going to go. I'm not very good at predicting how long it's going to take to get there. Bill Gates said we always overestimate what technology is going to do in 2 years and underestimate what it's going to do in 10. And so I'm going to pick somewhere in the middle. I'm going to say 5 to 7 years. We'll start
we're going to have
some autonomous tasks in the OR.
What about for the microvasculature?
That is highly dependent on how fast the companies that are doing that work move. Mm-hmm. So, that's like an MMI question to a large extent.
Yeah.
But look, they're following the blueprint of
the small bowel anastomosis.
That's already happening in the STAR system in Hopkins she's referring to.
It's pretty similar.
Yeah. Absolutely. Yeah. And
you have to be open.
And that's always been the thinking is this is such an obvious target for this. It's a small working area. Its structures are easily identifiable. You want it to be almost the same every time. So standard operating procedure and as little clinical variability as possible. And so it seems, and you're doing the same thing again and again and again. There's not a lot of judgment involved in that. There's a bit, but not a lot. And so it seems to me that it's a very ripe target for autonomy as a task, much more than dissect the deep pedicle. There's a lot you're thinking about there. There's not a lot you're thinking about when you're.
But even that,
even that, right?
You could just software plan it, right?
Exactly.
Just take all these branches, keep that intact.
Yeah. Follow the blue and the red.
Yeah. And Dr. Kayuk, who's one of our urologists here, who's probably one of the best single port surgeons I would think in the world, he did robotic dissections of the internal mammary vessels, the artery, I guess, specifically for cardiac surgery. So you could see that could be, because I know they have done some of the robotic anastomosis of the dorsal vessels. The only thing is that the IMA is such a good inflow.
I know. They're doing that. They're doing that in the context of the robotic nipple sparing mastectomies, where they have that access. Yeah.
Yeah.
But that's how they started doing deeps.
But I just love those internal mammary vessels. I have a friend that's a thoracic surgeon, and I was like, do you know that what we do to these vessels?
Yeah.
They're not really super aware. So I think.
Yeah, I also like the positioning better. I find operating in the axilla, doing micro in the axilla, somewhat annoying.
Yeah, right.
Ergonomically unpleasant.
Yeah, I think most people do. With the ILR, not ideal. All right, so I'm going to one last question. I told you I would have
Mind if I hold my tennis racket? I think better with my tennis racket.
There you go. So because I asked the residents, if they wanted to ask you something, and they're curious kind of how you're able to do everything. You have a million hats.
Yes.
You present sane.
I present sane?
Yes. And so.
It's a good cover up. I'm doing that.
So, they're just kind of wondering how you pull it off and, for lack of a better word, like how you manage like a work-life balance.
Yeah, no, it's a great question. I would say I'm not amazing at it. I'm very good at doing a lot of different things well. I've always had a very like diverse set of abilities, and I find that's somewhat uncommon, but I've also nurtured those quite a bit.
But
I think
doing different tasks is a relief for the brain,
right.
Because there's a concept that like your brain needs to like not do anything, and it's actually better to do a different kind of task for the brain for it to actually rest better. So maybe the fact that you're doing so many different things,
I think
tennis,
there's something in that.
That you're actually resting, whether you realize it or not.
I think that's right. I think there's a refreshing aspect to doing different things rather than just hammering away at one thing all your life.
It's nice not to only have one thing as your identity. I also like have like a different background and came into medicine later in life than you did. I think that's kind of helped to be like, this isn't the only thing
that I am. Yeah. No, I think that's nice. But I mean, to get right to the point, I don't think my work-life balance is excellent. Okay. My personal life is pretty lean.
Yeah.
I have one person and 3 dogs in it. Yeah. And then I've got friends and family who think I don't call enough. But it's not like I've got a large operation that I'm running at home.
Yeah.
I've kept that intentionally lean so that I can do what I need to do at work.
Yeah.
But look, there's only 24 hours in a day, and there's only one of you. And you can only do so much. I can do a lot in a day, but there's only one of me, and I have to decompress too. And run out of time. Like, what my last 18 hours have been for the podcast. I sat in a boardroom with our executive board in Detroit for 4.5 hours yesterday morning. Went home, fed my dogs, hopped on a plane, flew to Cleveland, gave a talk at dinner on economics of healthcare, went and played 3 sets of tennis, and tried to get some sleep. They put me in the cadaver lab at 7 a.m. And now I'm doing a podcast, and then I'm giving a lecture, and it's Friday.
We're late to
welcome to Friday. So, I mean, I'm 52 now. Like I don't have as much gas in the tank as I did when I was 35. I'm aware of that.
Yeah.
And I'm also,
but you know what? Use it or lose it.
Use it or lose it. Right. But you're right about that. But also, like, you got to cultivate some stuff along the way so that it's there for you when you're ready for it. Yeah. And if you don't have loved ones and maybe family, I don't know. I never had the family on that side. I've always had it, on the parental side, but never on the progeny side. But those relationships are like wildly rewarding for me. And so then I'm like, geez, would I have that?
How many robotic children do you have, though? A lot.
You can't really keep track of the robotic children. Once they have your programming, then they just run them.
Still, you have single point of origin.
When people,
surgery.
So when people bother me about kids, I say there's more than one way to have a legacy. I have invested heavily intellectually and in my actions, in my legacy, and I hope it's useful to people and the world. I think having children would be lovely at times, and I feel like it's something that I will miss out on if I don't do it. Yeah. But at the same time, I know from the work that everybody else is putting in how difficult it is and how much time it takes.
Yeah.
And like I said, I only have one life to live and I'm only one person. So the decision is yet to be made with a lot of unknowns attached to it. Yeah.
Well, I'm incredibly grateful to you.
Thank you, Sarah.
Thank you for everything that you've taught. And like I said this last night, that you've been very gracious with like your teaching, and you haven't withheld, or you've kind of really like spread it. So many of us have kind of made our careers and names off of your back. So we're appreciate it, to you. And I coined a couple of years ago, it's the godfather of robotic plastic surgery. And thank you so much.
It's my pleasure. And we all stand on the backs of others, and that's how we continue to escalate things. So, there's an old, I think, Mark Twain expression that if you're leading and you're walking alone, you're just taking a walk. And I think for a long time in this field, I didn't get that quite right. Something like that. I think Mark Twain part's right. I think I screwed up the aphorism a little bit. But my point is, if nobody follows you, if you're leading and nobody's following you, you're just taking a walk. That's what it is. I think if nobody does what you're trying to do, you're really just taking a walk.
Yeah.
And it doesn't really benefit the world at all to keep your ideas close to yourself,
Right.
to be the one
Yeah,
person
'cause it's just gonna
who
die
can
with
do
you.
this work. That the mystique of that is useless if you get to a certain point and other people haven't adopted the stuff you do. You just appear to be a lunatic
Yeah.
or an
Well,
aberration.
and also the skill and whatever dies with you. And then it's
Correct.
like it never happened.
That's right. And so, this is partly it's my gift to you and people that have, come to work with me and partners at various times, but it's partly just the impact that I want to have on the world. And it's not monetary. It can't be valued in any way except for that and legacy. And, did I, as Steve Jobs used to say, did I make a dent in the universe? Probably not. But did I make a dent in how we practice plastic surgery and the lives of women who get this operation? I hope so.
Absolutely.
And am I making a dent in the way people think about AI in healthcare? I mean, there's probably a lot of people thinking about that, but insofar as robotics goes, I think I'm firmly in that space and thinking productively about it. So, my goal is to continue to be useful to the world, and the world seems to continue to have use for me so far. So,
Awesome. Well,
cracking
I
on.
hope you'll join us again for our next robotic conference to go out. That it's going to be August 13th.
All right, back to Cleveland, my favorite city. But
We're like
what did you say about the T-shirt? Sarah found a T-shirt that said Cleveland. At least we're not Detroit, right, or something like that. I live in Detroit.
It's all in. It's basically in love. We're like twin cities.
Yeah, it's
2.5 hours apart.
It's all love of flavor. Yeah,
we're the same. All right. Well, thank you so much.
Pleasure.
Thank you guys. Happy Friday.